Hi, and welcome to Chapter 4, Positioning for the Wrist. For the wrist, we're going to talk about 3 basic positions: PA, oblique at a 45-degree angle, and a lateral. A lot of institutions actually add the scaphoid or ulnar deviation view. Sometimes you refer to it as a navicular view. And then there's a couple other views that could be ordered by the institution, but not on a regular basis, and those will be radial deviation, carpal canal, and carpal bridge. So for lab this week, we're going to concentrate on the PA, the oblique, the lateral, and the scaphoid or ulnar deviation views. So there will be 4 views you'll be responsible for lab. For the wrist, pronate the hand, have them sit at the end of the table. Place their hand up onto the tabletop. You can use a 10 by 12 or a 14 by 17 digital plate. Pronate their hand, and you're also going to curl the fingers. When you curl their fingers, what that does is it drops the wrist down closer to the film, so it has a contact with the film. This is going to cause a decrease in OID, so there'll be a decrease in magnification, which will cause an increase in our recorded detail, or in computer language we call that spatial resolution. You're only going to need to do this for PA, but some places will continue that for a oblique. So it's up to you as to whether or not you want to do that in lab. But just as an FYI, most facilities don't do that, but you may be with a tech that prefers it that way. So for the oblique, you're going to adjust the angle to 45 degrees. Rotate the hand so the ulnar side is down and flex your elbow at a 90-degree angle. Your central raise will be for the mid-carpal area, and you should include your metacarpals and your distal forearm. So routine, PA. If your patient can't lay in a PA, then you're going to do AP. You're going to do a PA oblique and a lateral. In a trauma situation, you'll be doing a PA or AP and a lateral. You're going to center to the mid-carpal area. An alternate to the PA is that AP wrist. Same thing, you're going to center to the carpal area. Basically, when we take a wrist exam, we want to make sure that we have enough of the phalanges and the radius and ulna to demonstrate on the film. So I like to open my collimation up to the 3rd MCP joint and then have a good 1.5 to 2 inches below the radius and ulna so that you don't miss a fracture. So your distal, radius and ulna, and carpals will be demonstrated. No rotation, and you should have diagnostic image, so an adequate level of density or brightness, and a short scale of contrast, which is also called a narrow dynamic range. Technical factors for the wrist, basically around 55 to 60 kVp. Digital, you're going to use 55. If you're using CR, you'll probably be about 60 kVp at about 2.5 or 5 mass, depending on the size of the wrist. Make sure there's no motion. You'll take the 10 by 12 image receptor, again 14 by 17. If you are using digital, arch that hand so that you curl the fingers to bring the wrist closer to the image receptor. Center to your mid-carpal area. Open up the collimation. You see how tight this image is? You really want to make sure you include those phalanges on your film. You can't just include your carpals. That's not enough for the radiologist to read. So your SID should still be at 40 for all of these, and if you can't do PA, do an AP. And then again, make sure you have collimation, but not too much collimation, otherwise you're not going to have enough area of interest for the radiologist. When we're evaluating our PA wrist, the mid-metacarpals to the distal radius and ulna should be seen. On this film, you can see that they are not included, so this, I would not submit this film. You can also see that there's no marker that's on this film. So your film should be a true PA. You're going to have collimation, but you don't want too much collimation to cut off the area of interest. Make sure you have optimal density, a short scale of contrast, no motion or tissue. You've curled the fingers to decrease distortion, and that causes an increase in spatial resolution. Your oblique wrist. Again, you can use those positioning aids with the sponge. So in this one, they put them in a nice 45-degree angle. You're going to center at the mid-carpal region. I want to see you open your collimation up to those third MCP joint. So center to the mid-carpal area. Use a 10 by 12 or a 14 by 17. Slightly higher technique than the PA, so if you're using 60 at 2.5, you could go up to 60 at 4. Pronate your hand and rotate at 45 degrees. Center to the mid-carpal area. Sit at 40. Collimate. You will use shielding on all of these. And make sure you have your markers. So again, when we're looking at this film to the right, it's not an adequate film because your markers are not placed on it. So distal radius ulnar carpals demonstrated, center at the field of the metacarpals. Your trapezium should be seen in its entirety, and your exposure factor should produce a nice diagnostic film. This is an example of where they left their fingers curled, which again, there's not a problem with doing that. And you can see they clipped off their marker, but at least they have evidence of the marker being on their film. Lateral wrist. You can use a sponge to place them against. Basically, you tell them to do a karate chop and put their hand in that position. And again, if they don't know what to do, just show them with your hand and demonstrate it. So your hand and wrist will be in a true lateral. You're going to center to the mid-carpal region, just like you did in the previous two. Use a 10 by 12 or 14 by 17 digital plate, slightly higher technique than the oblique. So now you're probably up to about 60 at 5 kVp, 60 kVp at 5 mass. Your thumb up, true lateral. So a lateral to medial projection, center to the mid-carpal area. Collimation. Sit at a 40-inch, have them have shielding on, and it's a tabletop exam. So here is a nice example of a true lateral. So the radius and ulnar are superimposed. You can see the carpals are superimposed. They could have did a better job at superimposing those phalanges, and they should have included a little more of the phalanges up to that third MCP. Here's the marker. And so overall, is it worth repeating? No, you can certainly pass this one. It's just if you were to do a repeat, you would want to include a little bit higher on this film. So center at the field of the metacarpals, no rotation. Exposure factors, this would be 60 kVp at 5 mass. Special projections, the one that we're going to focus on is that PA axial ulnar deviation. You can do radial deviation depending on what they're looking for, but most places are going to do the ulnar deviation. Some other things that might be routine, I worked at an ortho office and we used to do the carpal canal as part of our routine. So just as an FYI, if you work in an ortho field, you'll probably have these attached to your routines. Keep in mind that your scaphoid, which is also called the navicular bone, is the most commonly fractured carpal. So anytime they're suspecting that there's a fracture of your scaphoid, they're going to do that ulnar deviation view. So in here, you're going to use your central ray 10 to 15 degrees. You're going to aim that cephalic so it's going towards the patient's head. The patient's going to pronate their hand on the table, and they're going to flex that wrist out towards the pisiform. If there's a trauma, then you don't want to do this view, but you can use a 10 by 12 or a 14 by 17 digital plate, positioned just like you would the PA wrist, and then you're going to deviate as much as the patient can tolerate. Put on a central ray of 10 to 15 degrees towards the elbow, and then center to the scaphoid, or 3 centimeters distal and medial to the radial styloid or snuff box. I think sometimes it's easier to try to locate the scaphoid and center directly on top of the scaphoid. Sit is still going to be 40 inches, so make sure that depending on your angle that doesn't change. So you may want to measure that out and then collimate down to the area of interest. And make sure you have a marker on your film. So in this one you can see there's no marker, so that's their number one mistake. You can actually collimate down tighter because the area of interest is right through the scaphoid. And so positioning wise the film is fine, it's just they don't have a marker on it. So you should see that scaphoid clearly without superimposition. You can see the marker over here, and so at least there's evidence of a marker being on the film. Your scaphoid's not foreshortened. If you use more of a central ray, it's going to elongate the scaphoid. So this one's an example of a 25-degree angle. Here's a modified scaphoid. You could, instead of putting the angle on the film, you could angle with a sponge. The center ray is still the same. You're going to have them flex the fingers out so that the scaphoid is being demonstrated. And in this case, you just wouldn't use the angle. You would just elevate the hand 20 degrees. So ulnar deviate, 20 degrees elevated, central ray to the scaphoid. So there's 2 different ways to do it. I would say that for the ulnar deviation, you're probably going to see them putting the angle on the tube more than they would use the sponge. So in lab, I'll show you the way with the central ray, just because that's more of the common way to do it. So on this film, you want to demonstrate that scaphoid without foreshortening or superimposition, no rotation, and again, you can collimate down to the carpals for this film. If you're doing a carpal canal, patient needs to be set at the end of the table, and they are going to need to flex their fingers back. You can use their hand to do this, or sometimes people will use a piece of tape. Your central ray is going to be 25 to 30 degrees to the palm of the hand. No rotation of the hand and wrist. So when they lay down on the table, you just want to make sure that there's a natural 10 degrees rotation. If not, then you're going to need to slightly rotate them, but not by much. So in here, your carpals should be demonstrated. You should see the piece of form be thrown off of the carpals. And your hamate, so this is your hook of your hamate that's being demonstrated. And you should also see the scaphoid in profile. So your exposure factors for this one, about 60 kVp to 65 kVp at about 5 mass. So if there's no trauma, the carpal canal could be done. It's a tangential projection. You're going to hyperextend the wrist. You use your other hand to help stabilize. The fingers are going to be 90 degrees to the forearm, 10 degree internal rotation, 25 to 30 degree angle on your tube towards the hand. Central ray is going to be 1 inch distal to the base of the third metacarpal. And your SID still needs to maintain 40, so you'll need to use your tape measure and measure that out. And then also make sure that you include the marker on the film. So your carpals are demonstrated. They'll look like a tunnel. Your pisiform and your hook of your hamate will be separated. The palmar aspect of the capitate and scaphoid will be visualized. The trapezium, as it will articulate with the first metacarpal. And then you just need to make sure that you have optimal density. You're still maintaining a short scale of contrast or a narrow dynamic range. You should have no motion, and you should be able to see the trabecular markings on the bone. Your carpal bridge is one that they may request. I didn't see it too often, but that doesn't mean there's not an orthodoc that does it all the time. So in this, it's easier to stand your patient up and have them flex that hand underneath. So your hand is hyperflexed. Central ray will be 45 degrees to the forearm. And then basically you're going to collimate right down to that tangential view or dorsal aspect of those carpals. So your central ray is at the field of the proximal third MCP. Okay, thank you.